Yeah, so I'm
All right.
Fred DeJarly. Work here at NACC is the elder in residence, spiritual care, and I'm originally from Red Lake. I live here in Minneapolis. Wasamoganini is my name, and Anishinaabe Mon, it means lightning man, and I'm from the Bear Clan. So good to see everybody here today. Miigwech for letting me say some words on behalf of our gathering. Oh,
Language, Fred. Michelle, would you introduce yourself?
Hi, everybody. I'm Michelle Corcoran. I'm the nurse manager for the MAT program at NACC.
Rich, Nikki?
I'm Nikki Jardina, and I am the infectious disease nurse at NACC.
Tina?
I'm Tina Monnier, and I'm the harm reduction supervisor at NACC.
Rich, and thank you. I'm Kari Rabie. I'm the family practice physician, and I do MAT services here at NACC. Could we start thank you. So this is, of course, the Midwest Tribal Echo. We started with a prayer and land acknowledgement from Fred. Miigwech again. I'm going through the introductions and the agenda and the Zoom guidelines. Tina will be doing the announcements. I'll be talking about harm reduction in primary care today. If we have time for a case presentation, we will do that, and then Tina will close for us. As far as Zoom goes, please let us know who you are. Introduce yourselves in the chat function, your name, title, organization, email. You can right-click on your name on the screen to update it if you need to. Next slide. And then please turn your camera on if you're able to so we can see you. It just makes the conversation flow a little better. And we ask that you mute your microphone when you're not speaking. If there is noise coming from your square, we will mute it for you. Please don't take offense. You can use the hand raise function or the chat as needed. And then, of course, no protected health information. Tina?
Upcoming echoes. So August 3rd is TBD, and August 17th, Melanie Nadeau from University of North Dakota will be joining us, talking about centering culture and the treatment of OUD with American Indian, Alaska Native communities. There are a lot of different echoes that happen. One cool hub is the Northwest Portland Area Indian Health Board. They host this website called the Indian Country Echo, and you can find a lot of different echoes in there related to Native American care. And so if you want, any information about other echoes and links, please just reach out to me and let me know. Just another reminder that Stratus has launched their new website, Center for Opioid Resources and Education, another hub of resources, trainings, and stuff like that. And then Echo, so Stratus, our partner, who assists us in hosting this project, they are running a satisfaction survey. And so I'll be sending that out this afternoon. They just want to get an idea of who's coming and how people are liking not just this echo, but the other echoes that they help host. So look out for that in your emails. I think that's going to close on August 12th. Case presentations, as Dr. Rabie said, if we have time, we will do a case presentation. For those who aren't aware, they are real-life clinical scenarios that have presented challenging, complex, or new questions within our practices. It's a great way for all of us to learn from each other. And if you have a case presentation that you would like to bring to the group, please reach out to me and we can get that coordinated. This session can offer continuing education credits for eligible people. And you will just need to complete the survey that I send out after this session. So look out for that in your emails. And with that, I will stop sharing and pass it over to Dr. Rabie.
Rich. Sorry, one moment, just, there we go. Okay. So I'm going to be talking today about harm reduction in primary care. It's going to be talking about a lot of different concepts and also sort of a little bit of NACC's journey. I have no financial interests to disclose, and I'm not discussing the off-label use of any medications. So after today's session, hopefully you'll be able to define harm reduction in the context of primary care, discuss substance use disorder as a chronic disease, and formulate an approach for people with substance use disorder regardless of their readiness for sobriety. So, sorry, one second. There we go. So we are at the Native American Community Clinic in Minneapolis. We're a federally qualified health center, and we have integrated primary medical care, behavioral health, chemical health, and dental care. And our patients are about 87% Native American. When we started our journey towards harm reduction, we had identified a number of challenges within our practice that we became aware of, really because we for the first time got to see our data, and in our data we saw that our patients had a high number of avoidable emergency room visits. They had high prevalence of chemical dependency and mental health issues. There were high health disparities and high relative risk scores. We as a clinic were not connected to our whole community, meaning that patients who had chemical dependency who would come in, either sometimes looking for prescriptions for controlled substances, but also for other things, we really didn't see them as necessarily seeking healthcare. We saw them as sort of trying to get medications or to get medical opinion forms or to get other things that we didn't really see as being a part of their healthcare, and so we kind of marginalized them. So we were not connected to our whole community, and we had no strategy really for our highest risk patients. And here you see a graph that shows in Minnesota the drug overdose mortality rates by rate, looking at African American, white, and Native American, comparing 2015 to 2016. Here's a chart that shows our relative risk scores for our patients. We're the bar on the far left, and our patients compared to the other federally qualified health centers have had consistently the highest relative risk scores, meaning that they have a highest likelihood of dying or having serious health complications. Also, here you see the prevalence data for alcohol and opioid dependence, and you see NACC again, our patients have a higher prevalence of these conditions. And seeing this data really made us start thinking about what if we had the high prevalence of all these conditions, and we had these patients who are so high risk and expensive, which is of course what the health plans are concerned about. We really didn't have a strategy for helping them with that. So if a patient was using, we didn't really have a strategy for that at all. We also came to recognize the challenges that our patients faced within the system with systemic racism, trauma. Children had high out-of-home placement rates with CPS. There's criminalization of drug use. There's a lack of understanding on the part of providers of substance use as a chronic condition, a lot of moral judgment happening. There's lack of culturally competent care, lack of trauma-informed care. Our patients have historical trauma, and again, these high relative risk scores and health disparities. Also, there's a general lack of resources, lack of access to insurance, transportation, food, shelter, and with that hierarchy of needs, they a lot of times do not first address preventative, their health care, and especially not preventative health care. And sort of looking at these patients who were connecting only intermittently with the healthcare system and only in times of crisis, like through the emergency room or occasionally with us, We were sort of looking for a model to find a way to connect with those patients, and came across on the internet this quote by Johann Hari, which is, the opposite of addiction is not sobriety, the opposite of addiction is connection. And that really sort of informed our search for a strategy, and led us to harm reduction as a strategy, and sort of informs how we approach our patients. So we made this transition from the do no harm to harm reduction. And what harm reduction is interventions that are aimed at reducing the negative effects of health behaviors without necessarily extinguishing those, in quotes, problematic health behaviors completely. So it's a way to reduce harm and not to eliminate harm. So instead of telling a patient stop drinking, you sort of help them to find a strategy that works for them, and that may not always be to stop drinking, because that may not be their choice. So there's 6 principles of harm reduction. They're humanism, pragmatism, individualism, autonomy, incrementalism, and accountability without termination. And just a warning, there's going to be a lot of definitions and in this talk. So, and I'm going to be giving examples through it. I hope that you can follow along. So humanism, it seems like an obvious thing, but it really, what we see in our practice is to try and avoid othering patients and avoiding stigmatizing language. So, we don't call patients addicts. We talk about people with substance use dependence or opioid use disorder, but it's also always people with. We avoid saying that people are clean or that their UAs are dirty. The language really matters, and we a lot of times also see patients coming and using that language for themselves, and we sort of try to not to talk about it in that way. Humanism is avoiding moral judgment, and it's accepting patients' choices and working with them and not against them. So we are on the same side of the problem and not on the opposite sides. Pragmatism is accepting the reality of the situation. In a given using population, only 25 to 60% of people will want to or will be ready to stop using, and it is again important to have a strategy for those people who are still using. So we want to have a plan for them, and then also if they once they express that they want to stop using this, it's important to have a plan for relapse, because relapse is a lot of times a part of recovery. Our role as providers is to provide practical information about the harms of using behavior so patients can make informed decisions, but our job is not to make the decisions for them. And the other thing is to make sure that we're offering resources to keep patients safe. Even as they're entering into our MAT program, we're making sure that they have access to safer use supplies such as syringes, other supplies, and Narcan. I think as far as especially talking with staff about this, it's really important to recognize that some of the behaviors that our patients can demonstrate when they're still especially when they're still actively using, not always being honest about their use or honest about other things, and then other behaviors like taking things, stealing things. A lot of time it's a symptom of the disease. It's about where they're at. It's not about who they are. And I think that that's a really important thing to recognize. A lot of times people take it very personally. When I say people, I mean providers. When a patient is not honest with them, like they feel like that is a reflection of their relationship with that patient. And it's a reflection of where the patient is with their disease. It's not a reflection of who they are as a person. And really we should not be judging them for that. It's important. Individualism is respecting a patient's strength, knowledge, experience, and worldview. And this sort of intersects with the concept of cultural humility, which we'll be talking about as well. We want to empower a patient's perspective on what's healing for them, and to recognize that the medical model is just one model, and it's about sharing with them the decision making, help working with them to come to something that works for them. Trauma-informed care is also encompassed in the concept of individualism. It's important to listen and to recognize what patients need and to include them in their treatment plan. Also for an individual patient to recognize that what they need is going to change as their stability changes. So the boundaries and expectations for an individual patient is going to change and grow as the patient changes. And I think this can be challenging sometimes, especially for staff, because it feels like we're always bending the rules for patients. And for example, if a patient is new in recovery, or new in the program, we might be much more willing to accommodate them if they show up late to appointments, or if they need to get in quickly into the schedule, and we'll be more flexible with them than we will with somebody who's been with us for a while, because their stability has changed. Autonomy is important. Again, some of this is repetitive. Patients are going to make their own decisions, and to respect that, again, with the shared decision making, and recognizing that we are also learning from the patients. And again, as we mentioned in the previous one, the care negotiations are based on the current state of the patient. And then to respect that patients choose what they disclose. Just because we ask a patient a question doesn't mean that they have to tell us everything. It's their choice. So for example, if we ask them if they are trading for sex, for example, they may not choose to tell us that. That's completely their decision. But part of asking them is letting them know that that's a conversation we're open to having. Also, for example, with UTOX, is occasionally there'll be things on a patient's UTOX that are unexpected, like benzos or other substances, or maybe there's not Suboxone when there should be Suboxone. And I will ask the patient the question, and if the point of the question is to have a conversation and to open a conversation. It's not necessarily to have the patient tell us exactly at that moment. And how we negotiate that really makes a difference in the relationship that we develop with the patient. And all of these things help us to decrease the power differential, which is such an important thing in developing a relationship. And then also in this area, it's important to recognize boundaries and not, again, letting go of taking it personally when patients relapse, or patients are not honest, or if patients get upset and escalated. That's I think one of the harder things to do, and it's also an important part of trauma-informed care. It's important to recognize that this is not our journey, this is their journey, and we're there as assistants on the journey, but it is not ours. Incrementalism, this is an important one, recognizing again that relapse is often a part of a person's journey, and to celebrate the small victories. So many times patients will come in just so full of shame and regret after having, they've been sober for a while, and then they use and they come in, and we emphasize the fact that they stopped, they came back in, they're still engaging, they have come back and they're trying again. And I think that that's such an important thing to celebrate with them, as opposed to joining them in feeling bad about it. Accountability without termination. So as we've said above, patients make their own decisions, but they are responsible for the results of those decisions. So patients are accountable, and there can be sort of natural consequences. But at NACC, we do not terminate patients related to use. We're lucky in that we have a dosing clinic. So if patients are really unstable, or if we think that they're diverting their buprenorphine, or they just seem like they need more support, we are able to refer them to our dosing clinic. But there, for any Suboxone MAT program, there's always the option to offer a higher level of care. And there's always ways to offer them choices that continue the relationship, and sometimes just may not involve continuing prescribing buprenorphine, but I think continuing the relationship is an important thing. It's not our job to punish and to be the ones to create the consequences. So just really briefly, I just wanted to say where we are. We currently have 110 MAT patients. I think since 2016, we've served a total of 354 patients, other patients who are not current, but those who leave our program often stay connected and can return if need be. And some have, and of course, a portion of those have chosen to titrate off of Suboxone. Whoops, sorry, that's back, going the other way. About 80 of 110 patients, we prescribe buprenorphine directly, and 30 of them are served through our dosing clinic. We connect our patients to treatment through our IOP or elsewhere. We have 3 prescribers and 3 nurses, and as I said, we connect patients to treatment services. We offer an interdisciplinary team, so medical provider, nurse care coordinator, we have an infectious disease nurse, peer recovery coach, LADC, patient advocates. We have connections to behavioral health, community health workers. We have dental and elder residents. We offer nutrition, and then syringe exchange and outreach. And this is just a quick timeline. We don't have to review it now. One of the things I would like to mention, though, is co-location of services for patients who are least stable and struggling, and perhaps struggling with chaotic use. Having co-location of services like infectious disease services, wound care, syringe services, things that prenatal care at the same site is such an important thing in reducing barriers to access to care. So we have, as I mentioned, we have the RN care coordination. So at NACC, the features of harm reduction that I think are key is this idea of a chronic disease model that we use related to substance use disorder, cultural humility, trauma-informed care, this co-location of services, which I just spoke about. We're multidisciplinary, and we provide integrated care, and we try to be patient-centered, emphasizing smaller achievable steps and empowerment through education. So the chronic condition model for substance use disorder has like pretty much harm reduction has infused all of our care at NACC. And so we've come to really think of these things as very similar. So for example, a patient with diabetes may be called non-compliant with their insulin, but they're taking their oral medications and they're decreasing the amount of soda they drink. And so they're improving their care in that way. So just because they're not doing everything that the provider suggests, doesn't mean that you can't recognize the positive that they're doing within their diabetes. And for example, a patient with asthma may continue to smoke despite it causing wheezing. But then when you look closer, you find that they've minimized their exposure to other allergens and are using their controller inhalers as they should. And then, for example, with alcohol use disorder, a patient may continue to drink, but they may be able to have decreased how much they drink from 8 to 5 drinks, and they're taking a prenatal vitamin to make sure that they remain healthy as far as their brain goes and not develop complications. So this is just kind of like how we try to approach all chronic conditions at NACC with this harm reduction model, and to view the substance use disorder is no different from any of the other chronic conditions. So the important thing is that we're looking at it as a disease versus a moral failing. Nobody chooses to be chemically dependent or to develop heart disease, and chemical dependency and disease often change biology. Just like if you have diabetes, you can affect your microvasculature. Chemical dependency can change your brain chemistry. And relapse is common in both chemical dependency and other complex chronic diseases. And I apologize for the slide. Usually I would not use the word addict. I just want to mention the 7 grandfathers teachings. Mo did such a good job last time of talking about this, but this is important as we do our work at NACC to recognize. I want to talk about cultural humility. Cultural humility is the ability to maintain an interpersonal stance that's open to the other person in relation to aspects of cultural identity that are important to that person. So it focuses on being self-humility rather than what's going on with the other person. So it's like being open to where the other person is at and listening and hearing, and it helps to neutralize the power differential. Trauma-informed care. This is a great resource on the internet. I'll put it in the references at the end. But these are the aspects of trauma-informed care. Peer support is, I wanted to highlight, having people on staff with shared experiences, integrate into the organization, and as a resource for patients. Humility and responsiveness. Again, that's cultural humility. Empowerment, belief in a resilience and ability to heal from trauma, idea of collaboration with patients, again, reducing the power differential, trustworthiness and transparency, being really clear on how you're making decisions, and shared decision making, the goal of building and maintaining trust, and then creating an environment of safety where patients and staff feel physically and psychologically safe. And I would say, we're always working on all of these things. For example, lately, we've really been focused on the safety aspect. So boundaries are where an individual stops and somebody else starts, and having good boundaries is a really important part of providing care in this context. Individuals are responsible for their own feelings, attitudes, beliefs, behaviors, choices, values, limits, thoughts, and desires. And I think, again, this links back into the note that the understanding that people are responsible for their own behavior, and that when somebody else does something, it doesn't necessarily impinge on us, and we can keep our boundaries and remain focused on providing the best care that we can, rather than escalating with the patient. Again, very important, helps to address the power differential. And I don't think I've stated this explicitly, but just by being, as a healthcare provider, we have a lot of power, and it's really important to try and neutralize that as much as possible when we're caring for patients. So harm reduction policies that I would like to just explicitly name out are things like a syringe exchange, opioid agonist therapy, with some buprenorphine or with methadone. Overdose prevention is a harm reduction policy. Supervised consumption sites are an important example of harm reduction. In some places, they have heroin-assisted treatment. And then the drug court is an example of a harm reduction policy, and cannabis legalization. So just to give some sort of like policy level examples. For us at the clinic, it's important that manifests by meeting patients where they're at. We have protocols for actively using patients with alcohol, meth, opioids, IV, or other. We have counseling and resources around safer use, especially for IV users, but others as well. We provide screening and information around infectious diseases. This is a huge issue for a lot of our patients, especially those who are IV using, but all of our patients, really, HIV, hepatitis C, syphilis, hepatitis A. It's important to have a strategy to address that. We have resources, and we routinely ask questions around sex trafficking, and sex work. Having available an internal and external referral list to community resources is important. Treatment, mental health, spiritual care, and peer support. And then also providing patients with lists of material resources, or offering them material resources around housing, food, clothing, and transportation. So for people who are actively using for opiates, we can offer Suboxone or buprenorphine, methadone, as well as Narcan. For methamphetamine, we can expect increased impulsivity and impaired judgment. So we try and talk to patients' plans for safe behavior before they use. Also, sometimes we provided antipsychotics for patients who are using meth because of the meth-induced psychosis can sometimes happen. We routinely screen for HIV, Hep C, as well as syphilis and other STIs. For patients who are using IV, we focus on preventing HIV and hepatitis C, as well as infection and endocarditis, by providing counseling and education on safe injection and clean needles. For patients who are trading sex, doing sex work, or have experienced sex trafficking, we are focused on preventing sexually transmitted infections and just asking the questions and trying to create a safe space to have the discussion, to sort of figure out how we can help patients what they want to do or what they need. And then for alcohol, we offer prenatal vitamins, which have thiamine and folate in it, which helps to prevent damage to the brain. We counsel on using in safe spaces, on decision-making while drinking, sort of like just to avoid decisions around sex or driving or other things while you're drinking. And then we also offer naltrexone or Vivitrol as a treatment. Here is a list of resources that I talked about today. And thank you very much. And I'm sorry, I felt like I kind of rushed through that. So does anybody have any questions or comments or things that they've experienced in their place of work that they can relate to around that? Around harm reduction or trauma-informed care?
Hey, Dr. Rabie.
Hey.
Hi, sorry that I joined late. I had another meeting that ran late. But I really appreciated your discussion around boundaries. And I was wondering if you could unpack that a little bit more and maybe just some things around, because you mentioned like how to avoid escalating when like, let's say a relative of ours that we're working with becomes escalated. And I was wondering if we could maybe either like revisit that slide or unpack that a little bit more, because I know that can be a really challenging area. And when we get it right, it can be really beneficial. So we're not taking things home or taking things personally. So I was wondering if you might be able to revisit that.
Yeah, so a lot of these things, so the boundary thing is something that didn't used to be I used to be not good at it at all. I could feel myself, like a patient would get escalated and I could feel myself sort of come up with them. And I think that so much of that is this recognizing a patient's autonomy and that their journey is their own, and when I hear staff talking about it, like they get very upset that a patient is dishonest with them, for example. They feel like they thought they had a good relationship with the patient, but then the behavior that they're seeing from the patient, whether it's dishonesty or even stealing or something like that, they feel like is a personal betrayal. And so having a boundary in a sense of what's sort of you're responsible for and what the other person's responsible for, I think really helps to not escalate with the patient. And again, I see for our staff, a lot of times it's a sense of justice and fairness. They feel like a person is trying to get one over, trying to take advantage of their kindness, and that feels very hurtful to them when they've extended themselves to help that person. But again, if you can keep the sense that this is a professionalism and this is my work and this is what I do, and then the patient is responsible for their own behavior, and also some of those behaviors, it's not to see them as moral failings, but to see them as a symptom of their chemical dependency. So, and we've seen that so much of the time, and it's also a sign of where a patient is at along the continuum. So sometimes we've had patients and they're doing really well, and then they relapse, and then we start to see some of these behaviors again. It's like an indicator that that's where they're at. So I don't know if that's helpful, but for me, just sort of like having that whole way of conceptualizing it where it's not personal to me. It's not about me. It's about the work that I'm doing, and recognizing that the patients aren't trying to hurt me. Michelle, did you?
Can I? Yeah, I wanted to say, can you guys hear me okay? Okay. Sorry, one of my kids messed with my earbuds and it's like they're in sound canceling mode. And so it's a little weird. Anyway, we see this a lot with appointments, and we don't necessarily have the same expectations of keeping appointments and things like that for all patients, and we kind of change as the patient changes. So if somebody is, stopping and starting a microinduction and trying to, get into treatment and trying to get on a stable dose of Suboxone, but they, are homeless and still actively using, we recognize that it's going to be harder for them to keep appointments. And so we offer them more freedom and flexibility, right? If they're 3 hours late, like, we're still going to see them. They made it to the clinic. Like, we're going to do that. Sometimes they might come the next day, And that's okay. We have a provider available. We're going to help them. And we're going to, meet whatever needs it is that they have for the day. Where somebody who's been coming in and is, we see them once a month, they naturally tend to keep their appointments, right? And we don't have to offer as much flexibility. And so just not having these very strict rules, right, where you have to make your appointment or else you're not going to get seen for a week. Offering flexibility for those folks that are not in a place to keep appointments or go directly to the pharmacy and pick up prescriptions and things like that.
And to not get up, not to find yourself getting upset and escalated when a patient is doing those behaviors, right? Sorry, Nikki, you were going to say something?
Yeah, I was just quickly also just in response to unpacking the idea of like setting those boundaries with when patients do act in a way that the provider might consider to be aggressive or inappropriate or something like that. And just to you were talking earlier, Dr. Rabie, about that power differential within the appointment. And I think that that's also something that can be helpful to keep in mind, that it's not like two peers in which one is being aggressive towards the other. It's like a position in which, like, just speaking of myself as the service provider, like I hold the cards, I have more power in the setting, like I'm, in this situation where I'm in control, and there's like this sort of built-in safety around me of being in this workplace that protects me. And so then the patient or client having that sort of like lashing out experience at me is, I think, sometimes like a reaction to the power differential, as opposed, and so just to just to keep, and I think everyone can think of a time where they probably felt disempowered, and so they were a little louder or angrier than they would normally be because they felt disempowered and they felt like they didn't have control over the situation. And so I think it's like sometimes that can be a response to that and can help, like, just like you were talking about, Dr. Rabie, think about it in sort of a different framework than being yelled at or something like that in a different context, in our sort of personal lives.
And also we're trained, I mean, yeah, to be honest, like we're trained to think that we should be in power, right? That's how we're trained in the medical profession. So I think that just there's so many things. It's so important to try and neutralize that power. My father was a physician, and one of the things he said to me when I started working was, he said he always shook the patient's hand. He told me, this was years ago, he said, I feel a natural, sounds so strange to say, I feel a natural almost aggression towards the patient that I can neutralize when I do a handshake. You know what I mean? There's just like this, they want something from me sort of a thing. And so this is what he explained to me is like, if you do just a human thing like a handshake, it just is a way to dissipate some of that. And then there's other things that you can do as well to dissipate that natural sort of, here I am and you want something from me, it just, and like I said, I also think we're kind of trained that way. It's very hierarchical. The medical system is very hierarchical. And
as you were talking, Dr. Rabie, it made me think of the situation we had earlier in the week where we were meeting with a patient and we misunderstood something that was said, and our response to not understanding caused the patient to get escalated and kind of upset and defensive, right? And it was some people could have taken it as threatening or whatnot, but really it was just about, like, we had to calm down and just like, okay, think about what's happening here and talk through that. And it was just a misunderstanding about, a pharmacy thing, right? And then everybody was fine. But if we would have, met his escalation, we would have gotten literally nowhere. But we were able to just ask some questions and everything was cleared up.
Yep.
Super simple, easy fix.
Yeah, I had a thought too about that, but it flew right out of my head. Yeah, yes, I remember my thoughts. So like we also have a lot of patients coming to us requesting, because we hold the keys to a lot of things, right? We hold the keys to medications to make people, we hold a lot that can help people. And people a lot of times come in with an idea of what they need, we have that they need, or what they need from us. And so, and a lot of times the reaction of a medical provider is to be like, get really to resent or feel like those people shouldn't know what they want. It's our job to tell them what they want. They shouldn't come to us asking for specific things. And so, for example, and sometimes a patient will come and they'll say, patients will think that for example, medication, a controlled substance might help them, like a benzo, or they'll come to us thinking an opiate would help them. And we may not think that would be helpful to them, but there is a way to address that directly and not to try and avoid talking about it. Do you know what I mean? Because that is actually a strategy I've seen. It's so opiates a lot of times help with acute pain, but for chronic pain, we don't use those. Just say it just straight out and be transparent about it, as opposed to trying to sort of, let's not talk about this. And same like with the medical opinion form. Medical opinion forms, I don't know if everybody knows, is something I signed that can allow people to have access to benefits, food stamps, things like that says they have a medical condition and they don't need to work for a period of time, right? And so when people used to come in and be requesting medical opinion forms, I would go through this long speech of it's this medical opinion, and just explaining it before I got to what I was going to do. And it just made patients more and more anxious, as like, is she going to do this for me? I need this to pay my bills. I need this to, so if you can just right out of the gate say, I'm going to do this for you, and then explain it to them, that just makes such a big difference. If you can just transparently address what they just are like anxious to get out, this is what their need is. If you can just sort of right away cover it and then go into the explanations but I don't like it because, or whatever, and like some things I'm not going to do, like benzo, I'm not comfortable doing it. I feel like it's not actually that helpful, but just to start from the front end and saying, this has been helpful for a lot, and acknowledge some helpful in specific circumstances, but I am not comfortable doing it. If you need this is what you would need to go see this specialist. You know what I mean? And I find that I just don't have the same kinds of conversations with patients I used to have, where things got escalated, it got tense, people left upset. Not that never happens, but it's so much better. And we just navigate it every day, and it's about listening and trying to be open to where the other person's at. Did that help, Gia? Thank you. Thank you for asking that question. And any other comments? I don't feel like we have time for a case presentation.
Hi, I actually, I'm Heather. I work over at Avivo Village in our housing services department. I've heard about you guys a lot. So we balance this every day, meeting people where they are and that sort of stuff. I was wondering if you know of any like already made harm reduction plans. Like a lot of what we do is like informal conversations and like super individual, but do you know of anything that's like written out that's like specific to different kinds of harm reduction? So like a form about sex work or whatever, and like have like not like steps, but like laid out how like possibilities of, do you know what I'm saying?
Ask about specific risk, high risk behaviors, for example.
So like, and different strategies to reduce the harm that could be kind of like laid out, like if this is your baseline, what could be one step?
Yep.
You all have those resources?
Do you wanna?
Yeah, I mean, I think we have a lot of things that could fall under that category. So I think Michelle was probably about to say the same thing. So we can definitely send you quite a few resources and
And then feel free to have a conversation about it. If like, no, it's not, that's not exactly what you meant. Or a question about how it goes.
We can just make it.
Yeah, absolutely.
Okay, awesome.
Thank you for asking. Well, shall we wrap it up then? Yep, okay. Tina, you want to take us out?
Yeah. So I think that I said earlier that next session is TBD, but I think that maybe it's going to be Swetha, our in-house pharmacist, talking about the pharmacology around fentanyl, opioids, but I'll have to check in with her. And as usual, I'll send out a reminder to everyone. And Christy put a little reminder in the chat about the participant feedback survey for Stratus Echo participants. So the link is right here in the chat if you want to copy and paste it. Otherwise, I will send it out in an email as well. So thank you all for joining today. And thank you, Dr. Rabie. That was great.
Thank you. Bye.
Bye, everybody.
Who's got Tina? Do you want to take?
Oh, did I stop recording?